Bubble study, part 1, correct technique. In shunt from right atrium to left atrium, the blood flow and velocity is very low and cannot be detected by color Doppler. For solving this problem, we inject agitated saline through a peripheral vein. Agitated saline is a solution that consists of 90% normal saline and 10% air microbubble. Microbubbles are very teeny. Their size are between 20 to 40 microns, but they are very hyperecho, and in ultrasound we can see them very clear and obvious as you see on this image. When we inject bubble through the vein, in a few bits later, they show up in the right heart. And if there is any shunt between right to left, those bubbles, some of them or many of them, they come and show up in the left side. When we do bubble study, the most common indication for bubble study is rule outing right to left shunts. Like when we have paradoxical thromboembolism, is the time that we have some thrombosis forming in the venous system and come to the right heart and through shunt go to the left side and finally cause systemic thromboembolism. And patient, for example, get attack for TIA or stroke or any other equivalents. Or we have hypoxemia and we cannot find the reason and source for the hypoxemia. Another indication for bubble study is when we are dealing with the critical patient and we need measure pulmonary pressure, but we don't have enough TR for catching on Doppler, or we are not sure is that underestimating or not. In those cases, we can use bubble study for increasing sensitivity of Doppler study. Another indication for bubble study or agitated saline test is when we are suspicious to persistent left superior vena cava. In this venous anomaly, usually we see prominent coronary sinus. In that case, we go and do bubble study. For performing bubble study, we need two people, one ecotech and another assistant. Assistant is responsible for preparing, getting IV line and injection solution. In most center, usually is nurse, but it can be physician assistant, physician, or a trained ecotech. Equipment, we need 10 milliliter syringes, 4 to 6, one three-way, angiocat, normal saline, and band-aid. Nowadays, in most centers, the syringes are filled with 9 milliliter normal saline and ready to use. Which vein we inject? We inject in any major vein in the right arm, but if we have any restriction, for example, patient has AV fistula or doesn't have arm because of amputation or any reason, we can use left arm or even femoral vein. How do you prepare agitated saline? We mixed 9 milliliter normal saline with 1 milliliter air, and by using three-way and another empty syringe and pushing back and forth fast 10 to 20 times, all air divided to the micro bubbles and disappear in syringe and dissolve inside of the normal saline. Meanwhile, the assistant is prepared and getting IV and all set up. We go and set up our machine. Since we are recording as a clip, we go and saving time, saving time for 10 to 15 seconds. But with Valsalva that we do in next step, it's better we record time set up between 15 to 20 seconds. And we record in a prospective manner, but if you are comfortable, you can record retrospective. And then we annotate, for example, we put it bubble slash rest. Then we find a good four-chamber view. It doesn't matter subcostal or apical. We go first subcostal. If we couldn't, we go apical. Any of them that give us clear four-chamber, especially with both atrium and intra-arterial septum are clear and obvious, we use that window. Then we do bubble study in two steps, at rest and with Valsalva. At rest, just when you are ready and patient ready, assist and inject agitated normal saline 10 milliliter very fast through IV line in 2 or 3 seconds. And after a few beats, we will see bubble show up through the right atrium and then right ventricular. If there is any shunt bubble come to the left side, more than 2 or 3 bubble in the left side is positive, and we don't need to go to do Valsalva stage. Otherwise, we have to do bubble study with Valsalva. In Valsalva, we exhale against closed glottis. Is exactly the same way that we tight our belly or bear down during any activity or even defecation. So during Valsalva strain phase, we push bear down, the intrathoracic pressure increased. When intrathoracic pressure increased, the blood return to the right side decreased. But at the first second, left side increased. But total during 5 to 10 seconds of strain that patient keep pushing, always pressure on the left side is higher than right side. But right after stop straining and patient start relaxing, at the first few beats, 1 or 2 seconds or 3 seconds, the blood return to the right side increase, and meanwhile the blood return to the left side decrease. At those first few beats right after strain, at the rest, pressure in right atrium goes higher than left atrium, and if we have any degree of shunt, we can detect it on image. Before we start performing Valsalva and recording, first we have to go practice 1 or 2 times with the patient and explain to him or her that what is going on and how she or he should cooperate. And during that exercise, we find a good windows for recording during strain and after strain, and make sure we're having good windows with those changes. Our image are in good quality. When everybody is ready, we tell the patient, we hit the record and then tell the patient halfway breathe in and bear down or make his or her belly tight. At the same time, assist and inject 10 milliliter agitated saline through the IV line very fast, again in 2 or 3 seconds. And we are watching monitor and right side and left side. As soon as the bubbles show up in right atrium or 5 to 7 seconds after starting strain, whichever comes sooner, we tell the patient stop and relax. At that few moments that the patient stop and relaxing start, those moments are critical and we have to try catch it that time on our record. During that time that we tell the patient stop pushing and start relaxing, if assistant raise the patient arm up, it can improve our quality of image. If at the first attempt we will not satisfy with our study for any reason. For example, patient couldn't do very well Valsalva, or our view wasn't good, we can try and repeat this study one or two more times.